Ipsita Smolinski is the managing director of Capital Street, advising clients on biopharma legislation and health policy proposals through data-driven economic analysis. She holds faculty appointments at Georgetown University and the Johns Hopkins University Carey Business School, where she teaches healthcare economics and healthcare finance. Ipsita, it's always great to see you. How are you?
I am good. Good to see you too, and thank you for having me.
So before starting Capital Street, I'd like to just discuss a bit of your background. You were the Senior Equity Research Analyst for Healthcare Policy at J.P. Morgan. You were also at Bear Stearns for a while, from what I understand. You were working on Wall Street in the middle of the subprime housing crisis. What was that experience like?
All correct. So yes, started the Wall Street career at Bear Stearns, which, as you know, no longer exists, and worked at Citigroup and a few other places, really doing healthcare policy analysis. And JP Morgan as senior analyst was really exciting. You know, we were getting into the Affordable Care Act times. I would say being on the equity research side, I really had not much to do at all with the housing calamity. I don't have that much to add since it was sort of another side of the house. But of course, working at a bank with sales and trading, equity research, investment banking is a whole nother vernacular and experience like no other. So Capital Street, very different. We do independent research and analysis. It's never a dull moment at a place like JP Morgan.
I guess what's interesting to me about that period is if you look at the ratings agency and the federal oversight, there was a profound failure for the government agencies, the regulators, to appropriately predict the impact of some of the changes they'd made. Do you see similar parallels with some of the decisions that have been made around Inflation Reduction Act, where we're changing policy and changing regulation?
I don't know that I would go apples to apples on those two things. Certainly the IRA was a vast piece of legislation with things from climate policies to energy credits to, of course, the ability for Medicare to negotiate prescription drugs, which of course is huge given the non-interference clause and the wink, wink, nod, nod between industry and Congress for many years, decades, right? So I don't know that I see it that way. Now we've kind of crossed the Rubicon. And again, Medicare can negotiate drug prices incrementally, 10, 15, 15, kind of starting in 2026. Just like anything else, the CBO, the Congressional Budget Office, and other regulatory agencies made projections at one time that very well might have to be updated.
When you saw the initial projections from the CBO that it was only going to impact 2 drugs every 10 years. What was your position on that?
Candidly, we didn't perform CBO or JCT type analysis, but just as far as logic and common sense, it felt a little low. Again, we didn't run those projections. And of course, since then, we've had even specific companies say that it could be that magnitude of an impact on just one company. It feels like the magnitude is a little bit bigger than what we saw with those initial CBO projections.
So if we look at what the IRA was supposed to do, it was supposed to impact drug pricing. From your perspective, do you think it's been successful at that? What's your opinion on that? Is that going to actually have a positive impact?
Recall that there's 3 major provisions in the Inflation Reduction Act as it pertains to biologics and to pharmaceuticals. So you've got the inflationary rebates. That's the first pillar. That's the one where if companies are increasing their prices faster or higher than CPI, then they have to rebate that delta back to the government. That's the first one. The second one is restructuring Part D, which was a benefit that really needed to be modernized. That, I think, is very helpful to industry. There's now a $2,000 out-of-pocket cap, so seniors have more visibility on their out-of-pocket spending. And then, of course, the third is Medicare negotiation. And the first year of that will be 2026. Of course, we've seen the first 10 drugs and the price reductions. Look, we don't have great rebate data. There's a paucity there. So what it looked to be from our initial take and subsequent comments from other experts, other research organizations, and then companies themselves, is that really those first year of MFPs, maximum fair prices, are about on par with where prices would have been, excluding the rebate. So I'm not sure that prices are drastically lower, again, with that first round of prices, but I think we could see them have some more meaningful price reductions, in 2027 and beyond.
What's really interesting is the Inflation Reduction Act, when it was designed, they didn't just go for CPI, they went for CPI-U urban, which is a higher rate of inflation. And what's intriguing is if inflation's been running pretty hot, finally it's getting down closer to 2%. But for the last 4 or 5 years, inflation's been up 6-7%, and urban generally runs 2 or 3% above that. So it's really interesting. The inflation rebate, with the exception of a couple years, has not really come into play. It seems like there was an assumption that, inflation's never going to really be a problem. And then all of a sudden, it's still running hot. We would think that with tariffs and things coming in, inflation would still run a bit hot. What do you think has been the opinion now where they realize, oops, do you think they're going to try and change that? Or do you think that it was an unintended consequence of choosing the CPI-U?
I mean, look, you're right. Inflation was the highest we'd seen in 40 or 50 years, just a couple of years ago. From the company perspective, for the most part, they have been reining in price increases to be sub 10% or 12% anyway, because if you recall, over the last 5 or 10 years, the moment there was some type of steep price hike, you get plastered in the Wall Street Journal or the New York Times. So knowing that the microscope was on manufacturers already, I think meant that there was not as much of those steep price hikes that you were seeing versus 10 years ago.
Yeah, and a lot of the price hikes, as we all know, were in insulin. The IRA basically said, okay, insulin now is going to be $35, and that became hardwired, and that whole problem kind of vanished.
Exactly.
You were seeing enormous rebate percentages in excess of 70-75% on what is essentially a commodity product. It was pretty wild. If we look at the part about the rebates and the numbers here from the drug price negotiation, the maximum fair prices, we agree with you 100%. 66%, the average rebate runs about 55-60%, depending on which drug class you're looking at. Mm-hmm. The problem is those rebates have generally been used to hold down premiums. That's what the insurers have been doing with that money. What do you think is going to happen given the fact that the IRA doesn't actually have any penalties for the insurance companies saying, okay, we can't get rebates from this drug anymore. It's going to cause our premiums to spike. Well, we're going to start flipping this thing onto an unpreferred tier. I mean, do you think that's a risk?
There is an overall 5 or 6%, don't quote me on that number, max on premium increases year over year. So that is hardwired into the law. Yeah. And you're right that rebates buy down premiums. That's what's so great about them. You may remember back when the Part D benefit was passed. What was that, 20 years ago?
2004, Doug Holtz-Eakin.
Well, and do you remember just 5-6 years in, CBO and Congress was very pleased to point out that the spending on the program, the cost of the program came in below budget. And a lot of that was because of rebates.
Yeah.
So that's out there in black and white. I shouldn't be saying anything brand new with that statement. But as we go into 2027, 2028 is when Part B drugs, those are the injectable, the infused medications, biologics, we could see, again, higher discounts. Clearly, our Health and Human Services Secretary, CMS, the president has also said that he essentially likes the drug price negotiation aspect of this law, but the prices could be lower.
Do you think that insurance companies are going to start picking and choosing winners based on the availability of rebates?
With the new law, if you are a drug that's on the negotiation list, then as you point out, there's no more rebating. But think about if you have a competitor medicine. I think about Austedo and Huntington's disease. Well, think about the game theory and the three-dimensional chess we might be seeing that other manufacturers will be putting into place as they decide what their rebates will be. I think there's been that request made to the agency to keep an eye on what some of those formulary and placement tactics may be. I'm not sure that that's something right now that Congress and CMS is paying attention to, but I think they probably should be.
The law itself mentions that you're not supposed to change tiers, but it doesn't actually put any penalties for doing so. I would assume there's going to be a problem there, but again, we don't know. One of the other things we're seeing is the fact that IRA handles small and large molecules differently. Are you seeing with your clients an impact of that part of the regulation? Are you seeing a movement more away from small molecules, given the fact they only have a market position now of 9 years before they're hit with these price reductions? Are you seeing a move to the biologics on your side?
I have seen that. That's more anecdotal than anything that we could quantify at this point. Certainly after the passage of the Inflation Reduction Act, there were a few CEOs who came out and very pointedly said, we are going to look at this certain oncology medication in prostate versus ovarian, just given the larger market size, and also that the juice might not be worth the squeeze given the 9 versus 13 disparity there. It's pretty obvious from a number of the major companies who have said that they are focusing on biologics. They are focusing perhaps on immunology or conditions that aren't necessarily Medicare only, right? Potentially a younger population or a pediatric population. So nobody wants IRA risk, and certainly diversify their projects and their clinical trials to reflect the new law. I think that's pretty obvious.
Yeah, Vogel et al., the study that was published, Rita Conti and Amitabh Chandra, this was quoted in the Senate testimony of Rita Conti last year. That study is pretty clear. They say that anybody who's got a phase 3, they're not going to stop bringing a phase 3 to market. However, it also pointed out that those venture capitalists and angels further upstream would probably change the behavior. The study we published, the Inflation Reduction Act's impact on early stage venture capital investments, we analyzed early stage investments and startup companies working on indications for Medicare. And what we found was a huge move away from small molecules to large molecules. Really early stage, the VCs are really responding to these incentives to the point now where large molecules are 10x, 10 times the funding in early stage companies, small companies below $2 billion worth of valuations. And it's really fascinating because you're seeing this huge spike in biologics. Ipsita, what's going to happen if we create a Medicare incentive system where everything coming in is an injectable biologic? Has this been foreseen by the CBO and by the budget? Isn't this going to cause some trouble?
Well, it sounds like it would bust the budget just based on the initial prices that we see from a lot of those specialty pharmaceuticals. I don't know that they've fully modeled the impact. I mean, there's still, of course, a place for small molecules. I don't think that the sky is falling in that regard, but you're probably right that some of the financial models and projections would need to be updated. And I hope that more folks are reading the analysis that you just described.
I think that people had a tendency to look at all their analysis in the aggregate. They looked at sort of the average impacts, and obviously no investor is working in this space in the aggregate. They're actually looking at specific indications and specific exposures. It's funny you mentioned there's a place for small molecules. The obvious place right now are GLP-1s, these drugs for cardiovascular disease and obesity that are just blowing up. Those are all small molecules. And so what you're seeing is a move away from the Medicare age population in small molecules to cardiovascular disease. Was this on your bingo card that you'd see sort of a blow up of 1999 all over again, where we're chasing big cardiovascular indications?
When you and I testified in Congress talking about EPIC Act and the 9 versus 13, I believe I brought up SEMA and the fact that it is a small molecule. Folks who are not as necessarily steeped in healthcare and in medicine as we are don't know that just because it's injectable, so one would assume it's a large molecule. But as far as semaglutide goes, the prices are high. There's more competition coming to the market. We've got an oral coming that is very exciting. I don't know that anyone ever would have predicted a couple of years ago that we would see congestive heart failure, CKD, sleep apnea. I mean, heck, it's being tested in Alzheimer's and dementia, Parkinson's. So there's a lot of very exciting potential indications for the medicine. But look, just like any other medicine, it has its risks. We've got adverse events. And also would point out that semaglutide is on the negotiation list for 2027. So we'll see a lower price through that process. And actually, we'll see those prices and where they shake out in November of this year. What I would just say bottom line is that whenever there's competition, that brings prices down. And now you've got even Medicare able to negotiate that drug. As far as affordability to Americans, because it does treat such important conditions, I think that's going to be great.
There is a law on the books that Medicare cannot be used to treat diet basically as a substitute for weight loss reduction. Basically, you're not allowed by law to use those pills. You even mentioned Alzheimer's disease. I was at the CTAD conference where they presented the data where they had the first effective monoclonal antibodies treating beta amyloid plaque. And you actually saw that the responses could be predicted by insulin receptors in the brain. That's where we're getting a lot of this uptake in the GLP-1s for Alzheimer's disease and starting to get signals. Do you think that there's going to be the ability to do something around this with legislation with this Congress?
If you take the Medicare pie and take out the chunk with cardiovascular issues and the chunk with kidney disease, sleep apnea, I'm probably not even listing the full indication list, then you probably don't even have that big of a slice left for just pure obesity. But that being said, there is a bill in the Congress, affectionately known as TROA, introduced by Senator Cassidy, a physician from Louisiana who chairs the HELP Committee, introduced the bill a couple of years ago, has a pretty significant score. I think that score could come down as we see Medicare negotiate prices, more competition in the market. So I think that all the signs are pointing to lower prices one way or another. And even if you don't get TROA across the finish line in the Congress this year, maybe it'll be next year, maybe it will be the year after, but you really only have a small sliver left of folks that don't have those other comorbidities where they can, through Medicare statute, access that important medication.
One of the things we were discussing on the panel where we were in the Congress a couple of weeks ago, it's a month ago now, wow, it seems like yesterday. One of the things we were discussing was the EPIC Act. The EPIC Act was not included in reconciliation, but it's still out there. And the EPIC Act would basically solve this 9 versus 13 and put everything at 13. Now, the CBO has scored this at $13 billion. And I guess that's one of the benefits of having such a low score of an impact initially. It's that we assume that they actually didn't think the impact of the bill was that big initially, even though we disagree. But now you actually, to fix it, doesn't cost that much either. So I guess that's the upside. What do you see as the direction of travel for EPIC now after reconciliation?
Well, to your point, one big beautiful bill is the main goal right now. The president wants it on his desk by July 4th. I think that date could slip, but I think at the end of the day, it'll get done. EPIC Act was not included in that bill. The orphan drug fix was included, which is something that we said was a distinct possibility going into this whole exercise here in 2025. I don't think it's lights out for the EPIC Act. I think it could go at a later date. You may have heard that drug pricing is a big initiative for the president, for the White House. He certainly wants to enact pharmaceutical tariffs. He wants to go back to a policy that he started in his first term, which is called Most Favored Nation. So drug pricing is very much front and center and certainly a headline issue for the industry. I think EPIC Act, you're right, given that it's not in one big beautiful bill, it doesn't mean it's not going to happen, but that was the main train leaving the station.
Yeah, and now we're dealing with Most Favored Nations. I'm glad you brought that up. If you look at the 60% of GDP comparator to the United States for the basket of countries that we would grab from the price, you got Luxembourg and South Korea, you're talking 80, 85% reductions in price. The first time he tried to do this, when Trump tried to bring it out, there was a court case filed by California Life Science and Bio. The injunction was held up, and the Biden administration decided not to fight it and let it go away. What do you think happens? Is this going to be law now? What do you reckon? Is this EO going to stand?
Well, the EO, the executive order in it of itself, is largely a press release. This is something we want to do. We'll take some steps to get there. But the EO in and of itself doesn't mean that much. What I think is more meaningful are the next steps contained in that EO as it pertains to Most Favored Nation. The administration says that HHS will send price targets to the companies by June 11th. It sounds like maybe some of those prices have already been shared. We don't know with which companies. Is it Medicare? Is it everything? It's unclear. We would assume Medicare, but it's not explicitly written in that executive order. The real goal after that, if companies are not willing to play ball on MFN pricing, is to have a pilot through the Center for Medicare and Medicaid Innovation, which could do some type of MFN pilot program through the authorities that they have. That feels like the path forward. So it's not stroke of the pen, we have MFN. It's more, we want companies to play ball with us. We're going to provide target prices. If that's not something that they agree to do, then we'll go through a rulemaking process. And again, it was shot down the first time. Folks at HHS, in the White House, at CMS have learned from those setbacks and would likely take a smarter path this time around.
Yeah, I think the challenge for the industry then would be trying to go into a European country and say, we need to go up 6x in your price. Because unfortunately, and I do not think the calculus in DC has been done on this, but the reality is there are things called compulsory licensing under the World Trade Organization. And if your only option is, I need to increase this price 600%, or else I'm going to lose 70% of my profitability in the United States, your only option then is to pull the drug. But then you're exposed to a compulsory license because you're not providing access to the drug. And the government can claim this is an emergency and this drug needs to be provided. And they are then entitled under WTO rules to action a license on the patent. I mean, this goes down a slippery slope pretty darn fast. What do you think the scope is for companies to actually manage this when it's in a monopsonist negotiation with a government? Do they really have any power here?
Well, and you bring up a good point. Part of the EO and certainly the accompanying speech that President Trump articulated very clearly when he signed this most favored nation EO was that he, the United States, would help drug makers negotiate stronger with foreign nations, with the goal being that other first world nations would be paying prices that are much higher than they are today. I see that as less likely, but this idea of fairness, of equalization, is one that means quite a bit to President Trump. He talks about it when he talks about tariffs, and I think with most favored nation, the two policies are very much linked in this idea that we want Americans to get the best deal and that there should be some fairness and equality.
A lot of the companies selling in the United States and have huge operations here, Novartis in New Jersey, et cetera, Sanofi, they're European countries. We could be in the bizarre situation where the president of the United States is negotiating on a company that actually has operations in a country that's refusing to sell the drug at the price they get in the United States. This could get very strange very quickly. Speaking of which, this global nature of the industry, if we go back and look at 1980 to 2000, this was predominantly a European industry. 60-70% of all assets, all drugs were made in Europe. That at the time included the UK as part of the EU, but also Switzerland. If we look at what's happened since 2004 and the passage of the Medicare prescription drug benefit, which was designed in the bill itself, it said very specifically it was designed as an incentive to translate therapeutics from bench to bedside. What we've seen is an enormous exodus of early stage innovation out of Europe. Are we at risk here of pushing everything out of the U.S. to China? There's been enormous growth in China. Roughly 24% of all drugs currently under development are in China. There was a quote at J.P. Morgan this year that 73% of all the oncology applications and INDs for clinical research are coming out of China or have some sort of Chinese IP component. Do we risk throwing out the whole ball of wax here, Ipsita?
Look, having laboratories and operations in China is nothing new. Every major American pharmaceutical company has operations there, whether they're deconstructing patents, adding proteins and other molecules, doing clinical trials. The simple fact is they can get to first in human trials in China more quickly than they can here in the United States. I think there's something very alluring. And, what we continue to see is really this parallel development. Given the other IRA impediments and Washington regulatory risks, it's only going to make sense to be a little bit more diversified. I think that that's a trend that we're going to continue to see.
If you could make one recommendation now, Ipsita, to the Congress, if they came to you and said, okay, mea culpa, we kind of messed up here, what would be the one thing you'd want to do to try and fix things between now and, say, the midterms? What would be the one thing that you think would get the best result for patients and make sure we don't lose our industry to China?
Oh my gosh, that is such a great question. I think having a more clear regulatory roadmap with NIH, changes that we're seeing, FDA, we have a new commissioner, some new division leaders that are going on a roadshow themselves to meet with manufacturers and get feedback. I think having a better understanding of that regulatory pathway would be wonderful for manufacturers, since that's simply not very clear right now. Between now and the midterms, we should hopefully have some more clarity on tariffs and MFN. I think the real issue right now with biotech and pharma is that there's no visibility. We don't know if tariffs are coming. Are they not coming? Will it be on finished goods, or will it be on cost of goods sold? There's so many scenarios and no real visibility on tariffs or on most favored nation. No timeline either. So that has really, really weighed on the industry. A lot of the companies are trading at, multiples because there's no real certainty. So I think that would be the key. And that's what I would recommend between now and the midterms.
Ipsita, thank you very much for your time. It's been really great having a chance to speak to you.
Oh, thank you. Always a pleasure.
The producer of the Vital Health Podcast is Dwayne Schultes. Our editor is Mark Brodeen. Our project manager is Caden Drake. The Vital Health Podcast is a production of Vital Transformation, LLC, copyright 2025.